I help to kind of guide much of our diabetes prevention work at Intermountain Healthcare. Well, thanks, guys. I think I'm going to kick it off really quick with just a quick overview of the work that will be focused today. We will be first diving into the problem surrounding diabetes and chronic disease-related aspects related to lifestyle. We also want to talk about what will work to prevent chronic disease. Amy will focus on taking a history and developing a plan. We will also comment on using different aspects of teams, of care teams, to help deliver the care that's necessary for patients with prediabetes. And then finally, we'll do a deep dive, a very practical dive on the screening and referral options for both the Intermountain Healthcare System as well as the University of Utah Health as well. We also wanted to quickly talk, if you have questions along the way, please use the chat function on the webinar, on the Zoom platform, to ask any questions along the way. We have someone monitoring those questions, and we'll open it up for questions at the very end of this presentation. To start out, we really want to talk about the impact of diabetes to our populations. And I really, as a researcher, but also as a public health practitioner, I think a lot about the challenge related to trying to improve health and control costs within a health system. Here you can see some of the literature related to improving health and how long that will actually take and what actually aspects or domains will actually improve someone's health. Here on the slide in the table, you can see some of the literature that has been published suggesting that healthcare delivery will only impact a person's health by about 10%. What is also kind of clear or has been outlined in the literature is that behavior change and behavior aspects will actually contribute closer to 40% towards our total health and this ability to hopefully improve the way that we live and the quality of life that we have. So it's really about, as we start to think about diabetes prevention, this really dovetails quite nicely into this top box around behavior change and or lifestyle change, and allows our systems and our teams to really pull that small lever to really improve our health for our communities. To level set really quickly, we wanted to highlight some of the ways that you can be identified with having some glucose intolerance or hyperglycemia. First, you can see at the bottom part of the screen, we actually have 3 different tests that we will typically use in clinical practice to help identify people with different kind of abnormal glycemia. One, we have the hemoglobin A1C. We also have a fasting plasma glucose. And then we also use from time to time the oral glucose tolerance test. But in practice, that doesn't tend to be used as often as the other 2. You can see that you are a normal range. There's kind of this normal glycemia range. For someone with prediabetes, you can kind of see the range for the A1C. It is between 5.7 to 6.4. Someone with diabetes then will be at 6.5 and above. Also kind of focused on the fasting plasma glucose, normal glycemia is under 100. From 100 to 125, you would be identified with prediabetes. And then 126 and above, you would be identified with diabetes. We always start out some of our discussions around diabetes prevention, but talking about, the diabetes disaster. And I think that this is very significant as we start to talk about kind of the national landscape around diabetes and diabetes prevention. We can say that over 30 million Americans have diabetes, and the highest prevalence is around type 2 diabetes, where about 95% have that type of diabetes. We also know that about 1.7 million new cases are diagnosed. This doesn't exclude the 84 million Americans that have prediabetes, that condition that we had outlined in the beginning. And I think what's also very important about that number is that that means about 1 out of 3 Americans has prediabetes today. We also know that about 2 out of 3 people that have diabetes will die from heart disease or stroke. And sometimes we actually label this as the gateway diagnosis to other types of chronic diseases as well. We also know not only is this a quality of life and a health problem, but we know that this is a cost problem. We know nationally that the US spends about $237 billion with a B dollars per year on direct medical costs related to diabetes. And not surprising, when you see that figure, we know that about 1 out of 3 Medicare dollars is spent on diabetes. So this is our burning platform for how we need to actually transform and get upstream to preventing diabetes before it happens for our loved ones, for community members, and for our patients. I think the other thing that we would like to call out that I think would very much impact what we're doing is the future kind of significance on what this means for a clinician, living in primary care practice or in a specialty-based practice. We have data that has projected that over the next 5 years, a typical clinical practice could experience a 32% increase in the number of patients with diabetes on their panel. As we start to think about what that means, currently, we see that increasing over time and that having a substantial impact on the access and efficiency of our clinical practices within even the state of Utah today. Several of those challenges need to be called out that many of our practicing physicians will come in contact with. One, we know that we cannot address the healthcare needs of 84 million patients with prediabetes, of whom we know that 25% in the next 3 to 5 years will convert to type 2 diabetes. We know that our physicians and our care teams, including a lot of our nursing care management staff and others, do not have the time to counsel patients on the lifestyle changes related and required to prevent diabetes. We know that we do not have adequate information about those community-based resources that we know exist today in our state of Utah, and we need to have better information on how we can refer people to those already existing resources. We all know that social determinants of health are often the root causes or extenuate what the treatment options or the causes of diabetes. And we know that health inequities within our care delivery settings can also result in more in poorer outcomes as well. But I have a solution, and I think this is the time for hope. We know that diabetes prevention works. We actually have a study, literature, a study that goes back to 2002, where we have closer to 20 years of data that will actually show that diabetes prevention works, and it is able to reduce the incidence of diabetes among those that make lifestyle changes. This randomized control trial was implemented in a way to compare that to people on metformin, to the pill, as well to usual care, those just doing usual care activities. We were able to show a 58% reduction in the incidence of diabetes at 2 years among that lifestyle group compared to those in the placebo group. And not surprisingly, we also saw that much of that reduction was among an older population. So in those that were 60 years of age or older, we saw a reduction in the incidence of diabetes by roughly 70%. Not only does diabetes prevention work, the lifestyle change work, but we also know that it saves money. In 2016, the Centers for Medicare and Medicaid Services came out for the first time to suggest a preventative service to be funded by the government to actually talk about reducing costs and improving health outcomes. In that same study by the CMMI office, when we actually compared that to similar beneficiaries that were not in the diabetes prevention program, Medicare estimated that they saw a savings of close to $2,600 for each enrollee in that diabetes prevention program over a 15-month period as compared to the beneficiaries that did not participate. So not only do we have the evidence base to say that this program works and it helps people achieve better health outcomes and prevent diabetes, but we also know that this program can save money over the lifetime of the participation. I'm going to turn it over to my colleague, Amy.
Great, so next we're going to change gears a little bit and talk about what are the things that will prevent prediabetes. But before we do that, I'm just going to show in a different way what Kim was talking about in terms of the importance of particular risk factors for preventing disease-related death and disability. And as you can see in this slide, health behaviors like diet far outweigh other things that we think about in terms of diagnosing and treating patients. So even more than smoking, diet impacts disease-related death. Followed by tobacco, you see our kind of common things that we're looking at: high blood pressure, BMI, physical activity is still in the top 5, and then we see high fasting glucose and then cholesterol. You can see the list goes down with other factors, but when you bring this all together, we know that a healthy diet, regular exercise, and not smoking can eliminate about 80% of heart disease and about 70% of cancers. And we do not have anything else in healthcare that can have that dramatic of an impact. So the question is, how do we break this apart and help individuals begin to chip away at health behaviors to improve those outcomes? And so in the next few slides, we're going to be talking about really specific things in terms of providing advice. So physicians and other healthcare professionals, typically through training, don't get a lot of advice around health behavior change or about the specific recommendations. And so I'm just going to share with you just a few highlights. We could obviously spend all day talking about what makes a healthy lifestyle. In front of you on this slide is the University of Utah Healthy Eating Plate. And this really summarizes the best data for food and nutrition as it pertains to preventing basically most chronic diseases, whether that's autoimmune, cardiovascular, diabetes. And what you see here is a whole foods plant-based diet that heavily features vegetables and fruits with an emphasis on vegetables, whole grains, specifically coarsely ground, and we'll talk a bit about that, plant-based proteins primarily, but then other animal-based proteins would be lean, with a strong emphasis on healthy fats, water as the primary beverage, and then, of course, continuing to think about physical activity. So in the next few slides, I'm just going to highlight a couple of pearls that I find useful in talking with patients. I'm going to go back one slide. For many patients, it's just talking about vegetables, like how can we get people to eat more vegetables? But if they're a little bit more sophisticated or they're a little bit more interested in details, I will start a conversation around glycemic index and load so that we're all on the same page. Glycemic index is just a measure of how fast you digest food. So if you eat food that's digested very fast, your blood sugar rises very fast. And then your body responds, if you're healthy, by releasing insulin. Your insulin spikes and then blood sugar plummets. And so we know that over the course of a day, if a person is eating lots of foods that are very high glycemic index, that blood sugar rise, fall, rise, fall, rise, and fall will be related to all sorts of different disease states, particularly diabetes, but also autoimmune disorders, heart disease, and importantly for many patients, difficulty losing weight, even if their calories are the same over time. What's important to remember, though, is that glycemic index really has to do with how much carbohydrate is in a food. So glycemic load is a much better indicator of how much someone's blood sugar will rise. So for example, a carrot and a potato are both very high glycemic index, but a carrot doesn't have a lot of sugar, it's mostly fiber. And so you would have to eat a bag of carrots to get the same glucose impact as you would as eating maybe one potato, because a potato has a lot of digestible carbohydrate. And so when you're talking with patients, it's probably not helpful to give them charts and tables of glycemic index or to think about the specific numbers. But it's helpful to get in your head about how a food might impact your blood sugar. So if you're eating processed grains, if you're eating sugars, those are going to be things that you digest quickly and have a strong impact. And if you're eating more fruits and vegetables, coarsely ground whole grains, it's going to have a much slower impact. And so again, I wouldn't recommend focusing so much on the number, but more of the concept with most patients. The low-hanging fruit for most patients is in the area of beverages. When we talk about beverages with patients and we think about the barriers that limits people's ability to make changes, things like cost, ability to get to a grocery store, your ability to eat what your family wants and what you also think is healthy, all of those things go away when you're talking about beverages. It is interesting to note that when people consume calories from beverages, they don't feel full in the same way as calories from foods. And so we find that liquid calories more closely are associated with obesity. They are, of course, also more commonly associated with diabetes and elevated blood sugar. People can consume quite a large number of calories through beverages and not really change the amount of food they're eating alongside it. They often are very high glycemic index. And it's an important message that water is the preferable beverage. One resource that's very helpful, and sometimes I'll pull this up with patients, is nutritionsource.org. And they have this great figure, which I think can sometimes be helpful because sometimes patients are like, well, what about juice? I've heard juice is really healthy. And in fact, on the label for juice, it often says heart healthy. But that is in fact not the case. Juice has the same amount of sugar as sodas and other sweetened beverages. And if you see here in the yellow, what we're finding, and this figure was made a number of years ago, what we're finding is that their lobbying has resulted in a number of beverages that are now available that have low sugar and are not artificially sweetened. So this yellow category, these are things like your kombuchas or other beverages that are a little bit sweet, but are not very sweet, that you still feel like you're buying a beverage and you're getting, the excitement of getting a product, can allow us to make a shift without feeling like, okay, I'm just going to the tap and filling up a glass of water. But you can see those green would be ideal. So it's doing seltzer waters, Pepsi's new big campaign with bubbly has taken off. There are a lot more product options from folks that were not available even a couple of years ago. So a lot of people say, well, why can't I just switch to artificial sweeteners? I'll just go with my Diet Coke. And while I would argue that that is much better, so we see about a 50% reduction by switching to diet, what we do see is that we still have an increased metabolic syndrome or prediabetes risk when people are consuming more than 5 beverages a week. So that's less than 1 a day of a diet soda. And that risk goes up quite substantially with the number of beverages. So the more you're drinking, the higher the risk. And what we have some evidence to suggest that for folks who are trying to lose weight, when people are consuming artificial sweeteners, they tend to eat more calories through the day. And even if they hold those calories stable, they still have a harder time losing weight than if they're not eating foods with artificial sweeteners. All right, I'm going to switch gears and talk for just a couple of minutes about moving. So one thing that can be very helpful for patients is distinguishing the difference between physical activity and exercise. Because a lot of folks feel like, okay, in order to get a benefit to prevent diabetes, I need to go work out hard in the gym, or I need to go running. And so it can help begin that conversation by just distinguishing that physical activity is just anything that is moving. That can be yard work, walking to work, cleaning the house, whereas exercise is, I'm going there to do exercise. So I'm going to the gym, I'm going skiing, etc. And what we find is when we look at those side by side, that if you add them to nutrition changes, you lose weight equally well, whether you're doing something structured or not. You have equal impact on heart disease risk, but that for some people, physical activity can be more sustainable and easier to implement than a specific exercise program, and there's a substantial cost difference. So if you're talking about joining a gym or joining a sports team or being involved in a structured sport, there's often quite a bit more cost in terms of supplies and access than if you're just going walking in your neighborhood. It is helpful, though, to keep in mind that some sort of aerobic movement and resistance together seem to be the best if people are trying to lose weight. When we think about how much, we're still trying to get at least 30 minutes a day for most individuals. We know if people want to lose weight, it probably needs to be closer to 60 minutes. And that would be at a moderate intensity. So, a brisk walk. If people are familiar with METs, in the 3 to 4 MET range. If you're walking, you're kind of starting to feel like maybe you can't carry a conversation and walk easily. But it doesn't have to be all in one chunk. It can be in 2-minute intervals, 10-minute intervals, 30-minute intervals. You could do an hour and a half on one day and skip a day. But if you can help people focus on kind of those more intense activities, along a background of just being active in general, it can be more helpful. So for example, we know that people who are really active, they go and do CrossFit for 30 minutes a day, but they don't do anything for the other 23 and a half hours a day, but they're not going to be as healthy as someone who is just getting maybe a less intense physical activity, but spread out throughout their day. So you want these kind of bouts of exercise plus just kind of moving whenever you can. So looking for movement opportunities can be super helpful. This just highlights that these are the recommendations for diabetes or for kind of general disease prevention, but not specifically about weight loss. So there is quite a robust set of evidence that looks at physical activity and disease prevention. Kim already mentioned the diabetes prevention program, which showed walking was superior to metformin with a number needed to treat of about 7. Looking at a relatively active lifestyle, which is defined as about 30 minutes a day of brisk walking and less than 10 hours of TV per week, shows about a 43% reduction in the diagnosis of diabetes. The Health Professionals Follow-Up Study, which is the big study out of Boston where they're following physicians over several decades, has shown consistently less heart disease, cardiovascular disease, and all-cause mortality in those individuals who are active. So when you're thinking about physical activity, just remember it doesn't have to be exercise. And if you're doing something you enjoy, you're much more likely to continue. If you are doing something that you don't like or you feel is a chore, the second that something comes up, it's time to stop. It's raining, I don't think I'm going. It's a little too hot, I don't think I'm going. It's a little too cold, maybe next time. And it's really important to start slow if someone is really not currently active. So for example, you might see 2 people back to back with somewhat similar stories. And in one case, your recommendation might be, okay, I want you to get up and walk across the living room a couple of times a day and just start there. And then you might see the next person and you're talking about, planning for their next marathon. And so it really needs to be tailored to the individual, and small amounts add up to benefit. So if you go run the stairs for 2 minutes between your next patient, then that is adding benefit. It's not like it doesn't count if you don't do very much at a time. The third category in terms of lifestyle that we're going to talk about today is sleep. And sleep doesn't get a lot of press when we're talking about diabetes prevention. But what we know is that adequate sleep improves blood pressure, decreases rates of diabetes, stroke. It makes people more productive in their day. It decreases their risk of respiratory tract infections. It decreases the food cravings that lead to obesity and other disease states. And so sleep can be a really important way to talk to patients who are trying to make health behavior change. The other thing is that if people aren't sleeping, they often don't have the energy to exercise, and they often don't have the cognitive ability to think about making nutrition change. And so sleep is often where I will start with patients in thinking about how to get your foot in the door to start making health behavior change. It is important to have realistic expectations. So, if someone thinks that they really only need 5 hours, but they're just dosing caffeine through the day, it might be helpful to have a conversation that the average American adult needs somewhere to 7 to 9. Adolescents are going to need somewhere in the 9 to 10 range. There are a lot of things that impact sleep, and so dealing with depression, anxiety, other things that are impacting sleep. When are they taking medication that might make them urinate? And it's important to know that cognitive behavioral therapy is as effective as medications for sleep, but is much longer lasting than using medication. So cognitive behavioral techniques for sleep might include education around sleep hygiene. It might be addressing anxiety and coping. It might be working on relaxation techniques. But hopefully you will have access to those services to help patients in that way. So the kind of summary of lifestyle advice is that the general dietary advice, sleep advice, physical activity advice for preventing diabetes is the same for other people. You want to focus on increasing fruits and vegetables, increasing legumes, nuts. Whole grains themselves are not low glycemic. So if you take wheat berries, in a package and you start chewing on them, it's going to take you a very long time to get any kind of sugar or carbohydrate out of that. But if you put it in a Vitamix and just let it go, and now you have a pastry flour, you'll digest it very fast. And so trying to help people find products that have whole grains that are also coarsely ground can be helpful over those sugars and refined grains. And then really trying to avoid sweet beverages in general, rather than just trying to avoid sugary beverages. Keeping in mind that not only physical activity, but also sleep is important. And that if you don't know what people are doing, you really can't provide advice. You have to tailor the message to the person. And so when we think about doing that, you have to figure out how you're going to extremely efficiently get a history that gives you information you can act on. Because if you tell somebody who last year ran a marathon and is now just not sleeping and isn't physically active to do laps around their living room, they're just going to look at you like you're crazy. And vice versa, if you start talking about 150 minutes a week, go crazy, to someone who's completely inactive, it's not an actionable piece of advice. So this is the dot phrase that I use personally for physicals or for people for whom I feel like I want to get more information about lifestyle. Now, this is not super helpful unless you have a script in your mind already. So if you were in the University of Utah system, for example, you could go and steal this smart phrase and use it today. But I just use this as a prompt for me to remember to get through all of the issues. And so I might start out with a question like, how do you feel about your diet or the foods that you eat? And if someone says, I feel fantastic about it, great, then I might need to dig in deeper, particularly if they are pre-diabetic, but at least it gives me a sense of where they're starting from. How do you feel about physical activity? What kinds of things do you do to be physically active? How many hours of sleep? It just allows you to kind of quickly run through where some of the pain points might be. And you might find that someone's nutrition is fantastic, but they have had a sports injury and now can't be physically active. You don't want to spend your whole few minutes that you had to talk about lifestyle talking about vegetables. That's not particularly useful. And screen time is essential because recreational screen time is what you're doing instead of taking care of yourself for most people. So if someone says, I'm spending 2 hours a day in front of a screen or 5 hours a day in front of a screen, I had one adolescent who was spending 11 hours a day playing video games, then there's really not a lot of time left over to start making meals. And so you got to kind of know where you're starting from. So when you're taking a quick nutrition history, I often will ask just what sorts of places do fruits and vegetables show up in your diet? How often are you eating out? What kind of beverages? Where do snacks fall in? A 24-hour food recall can be a really quick way within just a couple of minutes to get an overall gestalt of what someone's eating. For example, what did you have for breakfast this morning? What did you have for dinner last night? How about lunch yesterday? What kind of snacks did you have? What kind of beverages? That's super quick and will give you an overall feeling of where someone's starting from. And of course, people are always saying, oh, well, yesterday was different because I had to pick up the kids and then it was late. And it's fine. It doesn't have to be the truth forever, but it gives you a starting point. And then the other question is, are you happy with the foods you're eating? Because if someone says, yes, like I love the food I eat, then it's a really different conversation than, no, this diet is terrible. I just don't have time to do anything else. Or I don't have money, or I don't have, equipment, or I'm homeless, or my family hates vegetables, or I have a kid with a strange food allergy. Asking people about cooking skills can be really helpful because you can spend a lot of time talking about eating fruits and vegetables, but most people can only eat so many raw fruits and vegetables before they're really getting tired of that. And then what kind of time and money constraints do they have? because people come to the table of poor nutrition from a lot of different spaces, and you need to be able to tailor your advice. So for example, in one family, you might be talking about what you can get from a food kitchen, and in another family, you might be talking about which vegetables are on sale at Whole Foods. When it comes to finding out about physical activity, just a quick question about what do you do? This is so much faster and easier than food. Many people are using some kind of fitness tracker at this point, and so I just now ask, like, do you wear a fitness tracker? How many minutes a day are you getting? And it just cuts to the chase. If someone says 2,000 or says 20,000, like, you already are immediately to a place where you can start the conversation. That's much faster than trying to pin down number of minutes, intensity, and frequency. And another thing that people will say is, oh yeah, I go to the gym. Oh, okay, how often do you go to the gym? 3 times a week. Is that every week? Oh, well, no, that was 3 times a week, but now I haven't gone in 2 months. Okay, well, let's find out about why that is. And then again, there's not a lot that people can do about work-related screen time, and so I really focus primarily on recreational screen time for most individuals. I love this quote. It's obviously not a new problem. This is from 1873. Those who think they have not time for bodily exercise will sooner or later have to find time for illness. And so it is really about kind of helping people find their internal motivation. And sometimes that internal motivation, most of the time, that internal motivation is not about getting diabetes or even about getting prediabetes. It's, how do I feel right now? Am I yelling at my kids when I get home from work? Am I able to sleep tonight because I got enough movement? Am I able to get through my patients in a day without losing focus of what I'm doing? And so helping people find those internal motivations can be a lot more effective in the short term. When it comes to sleep, again, super easy. How many hours a night do you sleep? Do you fall asleep okay? Do you wake up feeling rested? All right, so we're going to switch gears. We've talked about the problem of chronic disease and prediabetes and diabetes related to lack of physical activity. We've talked about some of the common advice and comments that we bring up with patients. And we now want to talk about, how do we get to a plan? How do we operationalize this information into helping patients make behavior change? And so we now know how to get a really detailed history. It's now time to start thinking about, well, what can you do about it? How can you set realistic short and long-term goals? And how do you, as a physician or another team member, engage the entire team rather than feeling like you have to turn your practice completely over into a conversation about lifestyle? And then how do you really reassess on a regular basis to help people keep making change? And so we're going to talk now about who is the team and what are your choices. We know that team approaches work. The Diabetes Prevention Program was a lay health coach-led group visit program. We know from the Look Ahead study, again, that groups led by dietitians, psychologists, exercise physiologists are effective. The ICANN study looked at dietitian-led case management, which is why we're starting to see payers begin paying for some group-led programs, although, of course, not quite fast enough. So when we think about who's in our office setting in primary care, the list on the left is basically what almost every clinic has. Some sort of provider, whether it's a physician or an APC, a nurse, and medical assistants. But increasingly what we're finding is practices that also include pharmacists, dietitians, social workers, psychologists. If you're super lucky, you might have a health coach. And so we are learning both how this improves not only the well-being of our patients, but also the well-being of our healthcare team. As those practices, for example, that have an extended care team often have much less burnout rates among their providers. There are a lot of health system partners that can come to the table to help with making an impact in this area. Specialties like cardiology, endocrine, orthopedics, surgery, they all have motivation to help their patients really make progress around lifestyle. We've also got disciplines like health coaching, dietitians, physical therapists, public health, pharmacy, psychology. If you have those groups in your health system or in your community, they can really help implement programming. Human resources can be a huge way to affect the population of employees that work at that institution. So for example, we've been offering the DPP for employees for quite some time. And human resources is often willing to pay to keep people at work to allow them to help get their health under better control. And then of course payers. The problem with payers is often that the return on investment for these sorts of things is quite out. And so being able to help them identify ways that will be useful financially in the shorter term can be helpful. Community partners are a huge resource. And so the best, most effective clinics that I've seen make use of community foundations, grocery stores, culinary schools, places like the YMCA, which has been doing the DPP for quite a long time, community garden, urban planners, thinking about public transportation. People's health is dramatically impacted by the community that they live in, their ability to have access to groceries, to access to safe places to move. And so if we just try to solve this problem in the physician office, we're not going to make a ton of progress. This really has to be a community effort. When it comes to interacting with patients, we already know that we can sit down one-on-one with them and chat. But what we do have now on the horizon are increasing numbers of group programs that are some billed and some out of pocket. Programs like the Diabetes Prevention Program, which has been around long enough that insurers are covering it. Newer programs like our Intensive Lifestyle Program, the State Living with Chronic Disease, programs like mindfulness-based stress reduction, emotional eating. Those are all creative ways to help people make changes. All right, I'm going to switch it back over to Kim. Who's going to take us through some of our remaining slides.
Thank you. You know, we wanted to make this very practical for our participants on this webinar. And so really, as we think about the rubber hitting the road for many of you on the phone and out in our communities, much of what we do is around how do we assess or screen for risk. And we have tools created by and validated by the Centers for Disease Control and Prevention, the CDC, around screening for prediabetes. Here on the screen, we do have a link. You can go to the platform, doihaveprediabetes.org, and actually take the risk test. Part of their campaign is that, truthfully, it will only take a minute to really determine your risk for prediabetes. We can see that a score of 5 or greater indicates that that person taking the screening test will have a higher risk of prediabetes and would actually qualify, as Amy had mentioned, for the group program for the Diabetes Prevention Program. You know, we also have great recommendations from the U.S. Preventative Services Task Force on recommendations related to screening for diabetes. Just in 2015, this recommendation was given a B rating, which means that it does need to be covered by commercial entities. Just to call out the screening recommendation from the task force is that those aged 40 to 70 years old, people with a BMI greater than 25 should have either a fasting plasma glucose, an HbA1c, or a oral glucose tolerance test every 3 years. And this is very important because it can actually be covered by many of our insurers. You also need to confirm those positive results and follow up those results with additional screening. We also know that women that have been identified or diagnosed with gestational diabetes during their pregnancy tend to be 7 times as likely to develop type 2 diabetes as women that did not get diagnosed with GDM during their pregnancy. Several risk factors for gestational diabetes is a previous GDM pregnancy, also being overweight, having an elevated cholesterol, having high blood pressure, or smoking, you know, and also, as Amy had mentioned, kind of this insufficient physical activity or unhealthy eating. We know that those are risk factors for a diagnosis of gestational diabetes. Now we'd like to kind of highlight practically what we can do at Intermountain, as well as the University of Utah Health System. We'd like to kind of lay out the facts for the exact programs that we offer within our system. At Intermountain, we offer a Prediabetes 101 group class. This is a 2-hour class that is free of charge. It is held in many of our clinics in our hospitals and is taught by certified diabetes educators. We also have individual nutrition counseling, medical nutrition therapy, which is a one-on-one visit with a registered dietitian. And then we have our Way to Health program. This is the program that is accredited by the CDC and recognized by the CDC. It follows the same accommodations for the diabetes prevention program. For some of our populations, we actually offer a web-based diabetes prevention program through our partnership with the Omada platform.
So we have basically the same types of things. We have our Introduction to Prediabetes, which is just the facts about prediabetes. This is a new online program that is about to be launched in either this week or next. We have also individual nutrition counseling at many of our centers, and then either an in-person or web-based national diabetes prevention program similar to the Way to Health in Omada.
When we talk about these programs, we wanted to highlight some of the actual kind of bullets around the accredited programs, our recognized programs. For Way to Health at Intermountain, this is a program that has 16 sessions over the first 6 months. And then we actually have monthly visits over the following 6 months. As I mentioned, Way to Health is actually mostly taught at our hospitals, at any of our 24 hospitals within the Intermountain system. It is taught by registered dietitians. Recently, we received preliminary recognition from the CDC, and we hope to become a Medicare diabetes prevention program supplier in 2019, which is for our Medicare and Medicare Advantage patients. We right now have insurance coverage through Select Health, and the plan actually covers 100% of the Way to Health program if you complete the program for those with commercial insurance. We have other select commercial insurers that will also reimburse for this program, and I would highly recommend you as a participant to even call your own insurance program and determine if you have eligibility.
So our program is very similar, 16 sessions over 6 months with 8 additional sessions over the next 6 months, so a total of 24 sessions over the year. As I mentioned, it's either in person or online. Ours are mostly clinic-based and taught by our health coaching team. We do currently have full CDC recognition and hope to have the Medicare supplier coverage in 2019. Current price is $50 a person, and we're always looking for ways to make it more affordable for patients.
Now, as we talk about some of our screening recommendations, we wanted to highlight within kind of our different systems some of those recommendations and how we have tools and decision support activities to help those screening guidelines. At Intermountain, we actually have 3 CENTRA advisories in production right now. Just to highlight those 3, we have one that recommends retesting of an A1C or a fasting plasma glucose if we see an elevated glucose from a chemistry panel. Additionally, our second advisory is around the lab screening, the U.S. Preventative Services Task Force guideline that suggests that adults aged 40 to 70 should be screened every 3 years. And then finally, our third advisory is around those that have identified lab-confirmed prediabetes. We will have an advisory that will guide the clinician to refer to one of our diabetes prevention program interventions.
And we have 2 current things that will show up. One is the Best Practice Advisory, or BPA, and as well as a health maintenance prop to screen people for prediabetes. We've started with a BMI over 30, and we're seeing how that goes. We may at some point drop it down to a BMI over 25. And this will trigger if someone has not had a fasting blood sugar or an A1C in the last 3 years. If the A1C does come back in the pre-diabetic range, then the BPA will fire again to advise you to refer to Consult Wellness, which will have a variety of choices. So this is the best practice advisory. So you can see here, it is suggesting that the last A1C was in the pre-diabetic range, and it's allowing you to either recheck the A1C or to put in a referral to wellness. And then on the CENTRA side,
same thing, you know, just kind of highlighting some of the advisories that we have around that. So,
okay. So here's the ordering of the DPP and EPIC. So if you type in consult wellness, there are two that come up. We're the second one. First is obviously oncology. When you pull that open, what you'll find is a number of options from diabetes prevention program, along with our other programs. And so in this situation, you would select diabetes prevention program. We'll then reach out to the patient to talk about whether they would want to do online or in person.
Now, as we talk about ordering our different interventions, our diabetes prevention interventions in CENTRA, many of our orders are order sets are around our Prediabetes 101 class. You can see that you can actually refer to different geographies within the state of Utah, and so we'd encourage you to kind of look for these order sets within CENTRA. Second, to order medical nutrition therapy, you would actually look and search for nutrition individual counseling outpatient adult. This is another order set within CENTRA. Finally, to order the Way to Health program, you'll want to look for Way to Health as it's labeled right here on the screen. I think finally we want to close up and say that we're very excited to have our first opportunities to partner together, the University of Utah and Intermountain Healthcare, to really bring you the facts and the knowledge that we have gained over the last few years working in the space to really prevent diabetes for the people living in our communities in Utah. Thank you very much, and we'll open it up for questions now.
All right, so thanks everybody for sending in some questions as we went. If you continue to have questions, please feel free to enter them in the chat, or if you have follow-up, please do feel free. So we had a question kind of basically on, does Medicaid pay for the diabetes prevention program?
In the state of Utah right now, Medicaid does not cover the diabetes prevention program, but there are 22 states that do cover this entity. So we are looking, as you were following the November election, where our Medicaid expansion was passed. We look to have further discussions into 2019 and beyond with some of our colleagues within the state of Utah to further that question.
Great. Thank you. So I'll go ahead and read this question and then give a quick summary. So this person mentions that the social determinants of health was mentioned earlier in the presentation as a root cause for prediabetes and diabetes. The presentation focused on healthy lifestyles. Can you speak to the interface of social determinants of health and healthy lifestyles, such as food, physical activities, etc., and specifically think about the access for individuals and populations that are affected by inequity because of where they live, and how providers can take into account as they provide education. So basically, to summarize, how do providers advise appropriately when social determinants of health are obviously impacting access to good health care?
I think the first thing that you can do is find out what the social determinants of health issues there are for the patient in front of you. So if you just walk in with your plan of 150 minutes of physical activity and half your plate fruits and vegetables, you really miss out on an opportunity to find out what is really impacting that individual. And I think some offices feel like, oh, well, there's nothing I can do in the face of someone who's homeless, or there's nothing I can do, you know, if somebody who's in a prison population. But even in the most restricted environments, there are things that you can do. And I think if you look at some of the really innovative programs that are going on right now in the States of going into high-risk schools, going into homeless shelters, and helping people find out ways to improve their health, even when they're recovering from drug addiction, it really helps you think that there's so much opportunity, even for those really high-risk people.
Thanks, Amy. And I would just add, you know, at Intermountain, we have started to pursue different screening tools to look at the social determinants of health. Some of the common screening tools are the Prepare or the Prepare Lite, so that you can actually understand what are the unmet social needs of the person using a validated screening tool. The other thing that I would encourage in the state of Utah is we have a platform called 211, and this is an actual platform that anybody can use to connect someone to community resources around food insecurity, housing instability, and whatnot. So just to kind of put in a plug for that work, and that might be beneficial to others.
Yeah, and I have to say that one of the examples that Dr. Locke provided that really stuck with me was even the example to get up and walk across the living room as a more accessible way to include physical activity. We have a follow-up to the DPP question. Where can we look to see which states provide Medicaid coverage for the diabetes prevention program?
That's a great question. I think what would be best, instead of giving you some incorrect information, I'd like to take that back and actually, I do have some websites related and published by the CDC that actually holds a registry of all national programs across the country. And so I think we can send it out through Sarah as we do some of the follow-up after this to really answer that question. I also want to put in a plug. I think Amy just whispered in my ear as well, that many of our community-based diabetes prevention programs have scholarships or also provide the diabetes prevention program at a discounted rate for people that have no insurance and or might be on different insurance coverage plans. So I would also encourage you to go to the state website as well. And once again, we'll provide the actual website so that we don't give any incorrect information. But I would encourage others to go to that website as well.
Thank you. So earlier on, we had a question about some of the data that Dr. Bruna Schultz had mentioned. So you were providing a lot of stats and statistics about the increase of diabetes over the recent years. And we had a question as to whether that was national data or local data. And maybe you could talk a little bit about the prevalence locally.
Yeah, that's great. Thank you for that great clarifying question. Through our colleagues at the American Medical Association, we were able to get access to national data looking looking at the data around the prevalence of diabetes as well as our future projections over the next 5 years. Right now, I haven't seen any of the projections related to any Utah data. Amy is also shaking her head no. What we do know is that right now we are among some of the healthier states when we look at some of our state level data that was published in 2015. Yet I would say, you know, as we talk about always doing better and really being able to kind of impact our own Utah communities, you know, good is not enough. We always need great and better. So we are really energized at really looking towards improving, you know, the prevalence and incidence of diabetes for our communities in Utah.